Okay, I'd like to talk about issues which are more or less possibly neglected in general, whatever YouTube videos. In this case, it's something which is more about opinion than about comparative science, because science is very little in this. There's lots of practice. So, as a psychiatrist, I would say I report more about practice. Many antipsychotics in schizophrenia are given as tablets, and there's quite a variety of tablets. However, in some cases, patients might choose that they prefer injections. Injections, they have some advantages. It's only that you have to give in injections every 2 or 4 weeks. Some patients prefer it, but sometimes they are under legislation, under the Mental Health Act in England. And in these circumstances, they are forced to take medications, and this can be delivered. There's some disadvantage of these medications because they just go into the system. Sometimes they have delays of working. So they're quite a different set of medications. And the way you choose is very little related to any science. So they're newer antipsychotics and they're older antipsychotics. So let's say I go through the list, say aripiprazole, flupentixol, fluphenazine, haloperidol, olanzapine, paliperidone, pipotiazine, risperidone, and suclopentixol. So there's some medications which are used in cases where people would prefer more sedation. So in these cases, that's suclopentixol and pipotiazine. These medications have a relatively long half-life. So if you just give them, it takes a while for getting a steady state. So usually in most antipsychotics, which are given as in a depot, it takes between 3 and maybe weeks, or let's say 48 days to put a full level of the dosage. So these medications also have to be given regularly, not daily, but regularly. So coming back to pipotiazine and suclopentixol, they're not very strong antipsychotics in the way of dealing with paranoia, hearing voices, what we call positive symptoms of schizophrenia. They sedate a bit more, and they can help a bit more when people are more anxious, and anxiety and aggression is a problem more than anything else. But these are things which come from experience, and details are very little in the literature. There are other fluphenazine, flupentixol, and haloperidol are a bit more stronger, working against positive symptoms. Haloperidol itself is one of the strongest antipsychotics. It's usually given in patients who already have experience with haloperidol, who can cope with that. And it's given initially at 50 milligrams. Every 4 weeks later, can be between 50 milligrams and 300 milligrams every 4 weeks. Usually quite strong antipsychotics, but haloperidol usually have nasty side effects. It can make people stiff and can cause Parkinson's symptoms. These symptoms are slightly less in flupentixol and fluphenazine. Flupentixol is less sedating. Fluphenazine is a bit more sedating. But again, it takes some time to find the right dosage. But these are very common medications. So what I've talked about now, were medication which we call first-generation antipsychotics. First-generation antipsychotics are medications which are, I would say, related or work a little bit like haloperidol. They have an antidopaminergic efficacy and can cause lots of Parkinsonoid symptoms like stiffness, facial, I call it weaknesses in the way that people have less facial expressions. They can affect walking. People can make small steps. They might fall a bit. So that's not a medication one would always like. Interestingly, one has to say some patients just take this medication as if they experience no side effects at all, and they don't. And in these cases, there's no problem giving this type of medication. In this interest of avoiding these old generation antipsychotics, which have Parkinson's symptoms as the major side effects, new antipsychotics, which initially were prescribed orally, have now developed sometimes depots. So one is aripiprazole, called Abilify. It's an antipsychotic which is not as strong as the other ones. It works slightly differently and has a minor dopaminergic activity, intrinsic activities. In this respect, the Parkinson's symptoms are much less. So in patients where it works, it's a good medication, and patients can take them quite long time. The injections are 400 milligrams monthly, and these initially it takes some while to get the medication started. So usually you have times that some medications will have to taken with an oral medication initially. But aripiprazole is a medication which, for patients where it works, is a medication that has very little side effects. We talked about the classics: fluphenazine, flupentixole, haloperidol, and zuclopentixole. So these medications are a bit from the older style. However, there's newer medications. We talked about aripiprazole. Risperidone is a bit on the edge. It's some medication as it's a metabolite paliperidone, that these medications can be used as antipsychotics. Usually they're not the strongest of all antipsychotics. They're not very sedating. So risperidone is usually quite common given at the moment in whatever 50 milligrams every 2 weeks. One can increase the medication. There's something which is important. During the time when you give a medication for 4 weeks, what happens sometimes is that the medication at the end of the 2 to 4 weeks is reduced, which makes sense. But what sometimes people then have breakthrough symptoms. So at the end of the 2, 3 of the period, of the usual monthly period, the symptoms might break through, which might then make sense to reduce the intervals. So give it the new medication after 3 weeks. So this has to be discussed with psychiatrists. Just an idea to talk about. Okay, paliperidone and risperidone are very similar medication. The advantage of one paliperidone is usually that it can give in a specific format every 3 months. So if patients don't want to come to the hospital very often, then usually it's a depot clinic which is adhered. It's run by a psychiatric department. So that's when patients come in. Sometimes GPs can give injections, but usually it's a depot clinic. At the depot clinic, there's physical health checks, usually blood pressure measurements and regular blood checks. So that's the advantage. The other advantage of going to a depot clinic is that there's a psychiatric nurse who might talk about symptoms and see how the medication works with these symptoms. There's a very recent development of Olanzapine, Embonart, which is an antipsychotic, which has a very sedating, very strong efficacy. However, this is a difficult medication to be given as an injection because there have been some patients where the injection didn't go into the muscle, it went into the vein, and then the whole of the antipsychotic went straight into the brain, and this led to severe sedation, and people were sleepy and had problems breathing. In this respect, there were some clinics where Olanzapine has been started, where patients have to be supervised for 3.5 hours to see whether the medication causes any side effects. Because of these inconveniences for hours, it's not very often given as an antipsychotic in a depot clinic. Right. So what's usually risperidone, paliperidone, and aripiprazole, even though not the strongest of all antipsychotics, if patients respond very well to that, then it's a good alternative to oral medication. So this is a general overview. I hope it helps a little bit. If you want to know something about individual medication, it's best to look at the BNF. The BNF is a British National Formulary, or any other textbook or guidance book or pharmacological prescription medication reference book. So you might have to look at that, just giving you some idea about this important point. And if someone wants more information, I'm happy, please write to us and let us know. Okay, thanks for listening, and I hope I can manage this Zoom meeting and without being too silly. Okay, thanks a lot. Bye-bye. Can start the meeting and stop it. That's a bit